Assalamu alaikum. We are starting the communication day. Patient Mr. David, 25 years. His mother, Mrs. Whitney. You are the doctor in the medical. You are the medical doctor in the rehabilitation ward. Mr. David had RTA, developed skull fracture, intracerebral hemorrhage, right side hemiplegia, craniotomy was done, it evacuated the bleeding. Now, Mr. David completed 5 months in the rehabilitation ward. He can eat and drink well. The right side weakness is still present, and he needs to be assisted by two persons to move around. He also occasionally has seizure, bowel, and bladder incontinence. No further improvement, and Mr. David's general condition has been static for the past 6 weeks. So the consultant decided to discharge him home, and if this option is not possible, then the consultant is happy for you to discuss the option of long-term nursing home admission. The task: discuss the situation with Mrs. Whitney, the mother, address any concern she may have. Start timer. Okay, ready?
Yes, right.
Here we go. Hello, I'm Dr. Mukhtar, the doctor in the ward today.
Hello.
You must be Mrs. Whitney.
Yes, I am the one, doctor.
You are the mother and the next of kin for Mr. David,
Yes, I am the one, doctor.
and he is 25 years old.
Yes, that's right, doctor.
Yeah, I'm here to discuss and talk about his condition. Is that okay for you?
Yes, doctor.
Okay, Mrs. Whitney, can you announce you like Whitney, right?
Yeah, it's okay.
Okay, Miss Whitney, can you tell me more? What do you know about Mr. David's condition?
Well, I know, doctor, that he had this accident, and this has led to this major bleed inside of his brain. And they have tried to improve his condition by doing some surgery for him. But unfortunately, for the past few months, he was only keeping up only with the care at the hospital. That's what I know.
Yes, I appreciate your knowledge about Mr. David's condition, and I'm so sorry about what happened to him and the suffer he already on. Can you tell me what's your expectation from this meeting?
Yes, doctor. I wanted to know if any more advances in his condition.
Yeah, I appreciate your concern, Ms. Whitney. Actually, starting by your concern, no change for Mr. David condition for the last 6 weeks. So his condition seems to be static, means no change, nothing happening with him apart from the last update, regarding his awareness, his weakness, and he had only residual abnormal movement, which is called seizure. And on that, he's taking some medication for seizure. Also, he had some loss of control about his bowel and his also water work. And are you following me?
Yes, doctor. Actually,
Yes.
they were telling me that his condition is better a little bit. Is that right, doctor?
Yes, compared to the condition he admitted with, is much better and he's stable now. And we are here to discuss about discharging him.
discharging him?
Yes.
But you're telling me that he has been really no much improvement in his condition for the previous 1.5 months, right?
I appreciate your concern, Mrs. Watney, but I'm saying that for the last 6 weeks, his condition is no further improving. I mean, it's the best condition he had since the accident. For that, we are, and for such condition, we are speaking to the relatives about taking the patient home as a good and suitable environment for the patient. Are you following me?
Yes, doctor, but this is really big news for me. I'm living alone at home, doctor. How will I take care of him, doctor? You're telling me that I have to take care of him? Is that what I understand?
Yes, I appreciate that, Mrs. Whitney. However, you can call any one of your family member to stay and to help Mr. David at home. He just needs some assistance to walk and roam around. Apart from this, he doesn't need any more care. Is that okay for you?
Actually, doctor, I'm really distant from my family. I'm living alone. I'm living in a different city. And actually, he was the one that was supporting me, doctor. So what you're asking from me is really difficult. Cannot you keep him more at at hospital, doctor? This is really difficult for me.
Yeah, I appreciate your concern, Mrs. Whitney. However, staying in the hospital with this condition is just might harm his condition because he might had or contract an infection from the hospital, and also he might have low mood because of staying away from his family and just staying with the sick people. That's why we are discussing the point of discharging him. Are you following me?
Yes, doctor. But how can I manage this at home? How can I? What I know that he will need full-time care, and as I told you, I really move hardly by myself. So how can I help him at home, doctor? This is really difficult.
Okay, Mrs. Whitney, if this is difficult for you and you cannot manage that, we have another option, which is called long-term nursing home. Did you hear ever about that?
No, doctor.
Okay, let me explain to you. This unit is for conditions such Mr. David condition. They are concerning for the long-term people who has some difficulty of walking, difficulty of coping with the daily activity, especially those after accidents. So if you are not able to take Mr. David home, we can arrange this unit for him. How would this sound for you?
Yes, doctor. Will this home be with somebody will help him regarding, I don't want any more problems for him, doctor. He is already suffering. So,
No, yeah, I appreciate your worry, Mrs. Whitney. Don't worry. They have nursing and also the appropriate stuff to help the people there and patient there how they can cope with the life. They assist them for the walking, for the dressing, and also cleaning and everything. It's like intermediate unit before discharging home. How do you feel about that?
okay, doctor. Will they allow me to visit him there?
Yeah, I appreciate your concern, Ms. David. Yes, Ms. Whitney. Yes, you can visit him there. They have their role for visiting the patient, and also they can take care of Mr. David for the private activity, like walking around and also some rehabilitation exercises. They can prepare him to be ready to discharge home.
Okay, this sounds good, doctor, actually. So, when will
Okay.
you transfer him there, doctor?
Yes, we will update you on the timing about that, about discharging him there. For meanwhile, can I ask you some question?
Yes, doctor.
Yeah. So you told me you are the one taking care of Mr. David, and he was the one taking care of you before the accident, right?
Yes, doctor. I was retired already, actually, and he was a really a good son. But unfortunately, after this accident, I am really alone at home.
Okay. Do you need any kind of support, Mrs. Whitney?
Yes, I would appreciate it, doctor. Yes.
Okay. We can help you in this regard. We have our team concerned for helping the family or for the patient.
Okay, I appreciate it, doctor. Thank you.
Okay. You have any other concern?
No, doctor. Sounds okay.
Okay. Meanwhile, I will give you some instruction about Mr. David
A minute for
future
me.
care. Yeah. Please, since he has this seizure, I can advise you always to take care of him, not leaving him alone. And also, yeah, you can also arrange for him with the occupational therapist to prepare the home for him to be ready to receive him as soon as possible after control his condition in the nursing home unit. Is that okay for you?
Yes, okay, doctor.
Okay. Any other concern?
No, thank you, doctor.
Okay. Also, I will hand you some leaflet brochure and website about the condition of Mr. David, along with the home long-term rehabilitation home center. We also provide you the hospital contact number. In case you have any inquiry, you can call us.
Okay, thank you. Thank you so much, doctor.
Okay, Ms. Whitney, any other concern?
No, thank you, doctor.
Okay, thank you for your time, and that's it. Okay, time is up. You can comment now.
Actually, this is I think a case about only explanation about the long-term care for this patient. She already is aware about the condition, and she's not. Maybe she's a little bit expecting some improvement, but she does not have high hopes. Yani. So yes, speaking about the short home, but she has no. She does not have the ability now to accept the patient. So the option of discussing with her that she can go to the home care or the long-term care after really making sure that she cannot um, giving him help at home. I think long-term care. I think the patient will be admitted there for a long time. I think it can be for years. This is what happens even in the kingdom of Saudi Arabia and other places. They have long-term care that will the patient can stay there for years, especially for the families that cannot provide home care for the patient. Thus, it is only about addressing the concerns and just telling the mother what will happen with the son. So yes, yeah, you did it very good, doctor. Yes. No other comment.
Okay, thank you, Dr. Any other special comment for this scenario?
No, you did great actually.
Okay.
We did it with the mentor before. Yes, it was the same as you did. Just
Okay.
it's about because I think it's a very simple case. Just addressing the concerns and assuring the mother. That's it.
Yeah. Okay. So
No
let's.
need to.
Yes, Dr. Bassem.
Yes.
Yes, the only thing when she asked why you are discharging him, it's not like he's not getting better. You should say his condition is static and stable. So patient is stable, can be discharged, and static means 6 weeks. It is written clearly in the scenario. His condition is static since 6 weeks. No further progression and no improvement also.
Yes.
So this is the phase of discharge. She cannot accept at home. Okay. Offer any family, friends, nothing. He will go for the nursery care. He can stay there, yes, like Dr. Sarah said, for years. He can stay there. If she
Okay.
refuse, why not to keep him in hospital? Same like you told, hospital is not good environment for him. Actually, nursery care is much better than hospital in his case, because he will see.
دكتورة
صوت راح.
the host interrupted.
Yeah, your voice. Doctor, can you check your mic? We can't hear you. Hello?
شكله الشبكة طلعتها.
I think she
Yeah.
إنه أنا أشرح له الحالة ولا هي already عارفاها، ما يحتاج أقول له عمل عنده كده وعملنا له كده.
لا هي
مش
عارفة عن
ما
الحالة، هي عارفة عن يعني she knows about the condition of the son. She had some hope but not that high يعني she's aware that the condition is not good. But the only concern for her is how to take care of the son.
أوكي.
Hey, Dr. Sararity.
Okay.
As I promised, you will discuss a scenario about Huntington. Okay, I'm just looking for the scenario, then I will share it. Okay, Dr. Sarah. Mr. John, 55 years, known case of Huntington recently. He was admitted with abnormal movement and dementia. Mr. Donald, the son, wants to meet you and to ask about the father condition. Sit with Mr. Donald and address his concerns.
Okay.
2 minutes, then we'll start.
Sorry, Dr. Bassam, I lost my connection.
No, it's okay, doctor. You can go ahead if you want to continue.
Yes, you also told her that he need only someone to take him walk around. He has incontinence. He has bowel and urine incontinence, so he need full care. Actually, she will tell
Yeah.
you, I have to go to work for like 10 hours, 12 hours. So really, he cannot be left at home alone.
Yes.
In this situation, we will emphasize the environment in the nursery care will be much better for him. They have well-trained staff. They know how to deal with such cases. They have a physiotherapist, like we told, for the rehabilitation. They have doctor, either a resident doctor or visiting doctor, who will come and follow up him all the time. So that's why it is better for him than hospital environment.
Yes, exactly.
He will have social, he can meet other peoples, he can go outside, and you can visit him there also at any time.
Yes, exactly. Thank you, Dr. Yusra. Yeah, but to be optimized at the task to discharge him home. So try to start by the home first. If not suitable for the mother, yes, that time the alternative option will be to home, to the
Yes, of course.
nursing.
Yes.
Yes. Okay, so don't start with the nursing home. You will start with the home. Sorry, nursing unit. You will start with the home till the acceptance from the family. If not, okay, we will go to the option of nursing unit. Okay.
You told her, Dr. Bassem, that social worker will help her.
Yeah.
Just tell her that I refer you. They can see if they can help you. Don't promise them that they will help.
Okay. Yes, better to say as much as we can, because yes, she's the mother, not the patient. Okay. Thank you, Dr. Aisha.
Welcome.
Ready, Dr. Sarah?
Okay.
Okay, here we go.
Hello, my name is Dr. Abdullah. I am one of the medical doctors here in the clinic today. Can I confirm you're Mr. Donald?
Yes, I am.
You're the son of Mr. John, right?
Yes, I am.
And he's 55 years old.
Yes.
So can you tell me more about what you know about your father?
Yeah, doctor. So now, since 2 years, my father was having some abnormal movement. Really, doctor, he was behaving weird. I don't know what he's doing. And for the last 2 weeks, I noticed also he's not aware about us and he doesn't know most of the things around. So we brought him to the hospital and they told us there is a diagnosis called Huntington. Really, doctor, I don't know about this disease. I try to collect more about this disease. However, I'm not aware more about that. Can you tell me and explain more about that?
Yes, actually, I wanted to know what are you expecting from our meeting today?
Yeah, I expect that my father, he will be cured and he will come back to the home with us.
Okay, so just so that you know, unfortunately, the lab tests and the imaging studies we did your father did not come as we hoped. I'm really sorry for that.
Yeah, doctor.
So, unfortunately, it showed that he has something called Huntington disease. Have you any knowledge about this problem?
Yeah, doctor, they just told me about, but I didn't understand the nature of this disease. I tried to read, but I can't understand what they mean by Huntington. That's why I requested to meet you and to explain for me.
So, unfortunately, Huntington disease is a disease that runs in families. So we call it hereditary disease. Don't mind the name of the hereditary. This means hereditary that it runs in families, and it's related to the genes actually. So that's why it can run in family.
Yeah, doctor. So what about the disease? Yes.
Yes.
And how possibility the disease will run in families? Can you tell me more?
Yes, yes, sure. Just be sure that we are here to help you, and we are here to give maximum support for your father and you. So Huntington disease, as I told you, is a gene disease. Unfortunately, it can appear if the father has this problem. Unfortunately, it can be affecting about 50% of his offsprings or his sons or daughters.
You mean everyone, doctor, or all of us? We are four, doctor. You mean two of us will have the disease?
Actually, I'm sorry to tell you that every one of you will have a 50% chance of acquiring this disease.
Oh my God, doctor.
I'm really sorry. And really, I'm assuring you that in our hospital, we have one of the best teams in dealing of this, what we call the genetic disease. Just don't mind the medical name. I'm mentioning it so that we can make this meeting easier. And we will try to help you and try to help your father as much as possible. So Huntington disease is actually a disease that will affect the nerves in the body. You know, the cables that responsible for movement of the body, for the memory and everything. So when a person have this disease, you will notice some like abnormal movement in the body, like shakings of the body. And also, unfortunately, some in the advanced cases, they will have a problem with the memory. So they will have memory problem. And as I told you, it has 50% chance of getting to every one of the children. And unfortunately, also, it's unpredictable when the children can have this problem. Are you following me, Mr.?
Yeah, doctor. Yes, yes. I'm trying to understand. Yes, doctor.
So regarding your father, as I told you, we have one of the best teams that can support him and give him the maximum support. They will keep him pain-free, and also they will give him the maximum support for him. That they will help him to go to the toilet and help him with his bowel motion and like with his urination, everything. Because at such stage, maybe now he will not suffer this one, but maybe in the future he will suffer this one. Also, if any social support for him or for his family, we can offer this one also. Because I'm really sorry to say that Huntington in such stage seems to be advanced.
Oh my God, doctor. Doctor, any cure for this disease? Can you give him some medicine?
I'm really just tell you that in such stage, it is really advanced disease. So, like I told you, we are going to give him what we call maximum palliative care. Oh, don't mind the medical name. Also, this means full support for him to keep him pain-free, comfortable as possible, and sorry. And
Okay.
also we can support the family.
Okay,
So,
doctor. What about me, doctor?
yes.
Any chance to have the disease? I want to do screening, doctor.
Yes, I appreciate your concern, Mr. Donald. Actually, this is my next topic in this meeting. We have to run what we call screening tests for all of four of you. This includes you, because you are the one that we are meeting today. So we are going to run some tests. We call it genetic test. So this genetic test is like going to appear within a few days, and it will be top. Well, it will have top confidentiality. Like, you are the only one that will know the result, and it will be handed to you hand by hand. And just so that you know, these tests, it can have some false positive and false negative results, but just because we are one of the best hospitals in this one, so be assured that we are going to run this test, and if there is any other issues in the future, we are going to help you with it. So
Okay,
running.
doctor. Thank you, doctor, for this offer. But can you, doctor, also give me medicine before the disease appear?
Unfortunately, as I told you, this disease is unpredictable, and till now, there is no specific medicine or specific surgery that can prevent that condition. I'm really sorry for that. But be assured that we're going to, if the tests come back positive, we will refer you to a group of doctors that can really help you regarding this issue, like the nerve doctor, even the what we call the gene doctor, especially nurses, everyone will help you regarding this one if the test comes back positive.
Doctor, okay, doctor. What if I want to have kids, doctor? Any
Yeah.
possibility also to be transferred to the kids?
Yes, unfortunately, if you have this problem, you can transfer it to the kids with the same percentage, 55%. I'm really sorry for that. So I advise you, in case of the test will be positive, we're going to refer you to the gene doctor again to help you regarding this issue. We can have something called selective fertilization, but this is still early to say. So now the most important thing is to do the screening for you and your siblings to make sure that you are free from this disease. Any other concerns, Mr. Donald?
No, doctor.
So can I give you the consent?
Yes.
If you agree to do this one, can we give the consent to sign this one? It will show you everything that you need about to know about this test, and also you can cancel the test whenever you want. Is that okay, Mr. Dolan?
Okay, doctor.
Can I will give you some brochures and give you some websites to help you understand more about this disease.
Okay,
And
time is up. Yeah, thank you, doctor. So I think you are waiting for the time to finish. I feel that. Yes.
okay.
No problem. We will comment now. So the introduction was great as usual, and you can also assure about confidentiality, because also this is one of the confidential
Yes.
disease. Yeah, need to be confidential and no one knows about.
Mm.
Of course, the father is dementic, so no need for permission. He's already dementic. So you can proceed further, but after confirming that he's the next of kin. And reassure him this meeting is top confidential. Don't worry, no one will knows about the result. I explained to you that I know about the result. They told me about the Huntington, so no need to repeat and to breaking bad news. I know already. So what you can say, I'm here to address your concern, and I will explain to you, because this is my concern. Can you tell me more about this disease? Yes, I'm here. I will explain to you. I will tell you more details about this disease, and I will address any other concern for you. So you can start explaining the disease from the pathology or the etiology. It's unknown, and it's running in family, as you said, in percent of 50%, and you can explain more. It's not 50 in the kids. No, everyone can have the percentage of 50% to have the disease. And also the one affected will give will again inherit the disease to the kids in the same percentage, 50%. So it's autosomal dominant. Don't bother about the name. When you want to say gene, you can say code. It's not, gene is a jargon. So you can say the code. It's disease on code, or means gene in our body. The code is responsible for transferring the characters from the father and mother to the son or to the kids. So finish this issue. The next issue for the second concern was about the cure. As you said, no cure from this disease. I'm afraid to say no cure, and just we will support Mr. John, whatever he needs, like feeding or any private support or any private nursing care. Apart from this, we can't have any medicine for him. Then the next point, which is screening, and this is the tricky point in Huntington. Screening for Huntington with no benefit at all. So yes, if you have the disease, you can come to us, or you have any symptoms, or you have any, and you can tell him the symptoms. It's a degenerative disease or breakdown in the brain tissue. And once it happens, so you might have abnormal movement, change of the memory, low mood. In this point, if you have, or any one of your siblings have this, of your brother or sister, please visit us. Apart from this, no any benefit from screening. What if you screen me and the result came positive? What I will have? What the benefit from this? Nothing. It's just stress and with no cure. So the best thing, what to do? Just explain and instruct me about the condition and the symptoms and signs. Don't forget the anticipation while explaining the autosomal dominant. I'm afraid also there is also bad news. What is it, doctor? What are these? I am afraid to say there is what's called anticipation. Means that the generation have the disease earlier. They have the disease in the late age. For the next generation, the disease will appear earlier, and the next generation will be earlier and earlier. So the symptoms and manifestation might be appeared for you and for your brothers earlier in the age than the father age. I'm so sorry for that. Oh my God, it's bad news. Yes, I'm sorry to be the one sharing this news with you. And don't worry, we will be with you and your father. We will support you and we'll give you the maximum support. And I'm sorry for what happened to your father. That's it. But don't offer any genetic screening. No
Okay.
benefit from this, okay? This is the tricky point of Huntington. It's different than Comm and different than autosomal dominant polycystic kidney disease. There is also tricky point if the patient, or if Mr. Donald told you, what about my brother? He is 15 years, or my son. I want to do screening for him. Why I want just to know if he has the disease? No, I can't. We can't do the screening until he will have he will be adult and he will decide for the screening. Along with that, no benefit also to know about his condition. The only thing you can do for Mr. Donald, as you said, the gene selection or the sperm selection, if he want to have safe baby from this disease. And this will be also arranged with the genetic counselor team. We have expert team, as you said, we have expert team. They can help you in this point only. Whenever you are planning, not only not already had the kid, no. When you are planning to have a kid, yes, we can do first. Of course, we have to do the test for him. This is the only point you can screen Donald himself to know if he has the disease for the future family. But for himself, nothing will be offered. But if he wants to have a safe baby, you can screen him first. If he has the gene, then you can screen or you can do what's called genetic selection or sperm selection. Apart from this, no any benefit from the screening. Is that clear? Then the closure, as you said, yeah, support and the care, nursing care for Mr. Joe. Don't talk about also any DNR. It might be as a hidden agenda. If they wrote for you, you can explain, but not for the first time. Since he's dementic now, you can also ask about advance directive. Any wishes from Mr. John? Did he express any wish while he was awake? Why, doctor, you are saying that? Because I'm sorry, I'm afraid maybe he will not be awake again. The condition already progressing, or the disease already progressive disease, it might also be worsened in the coming days. Okay.
Okay. I thought that the agenda was also to discuss the gene. And,
No, at all.
Okay.
So the two disease you can screen for autosomal dominant polycystic kidney disease, and HOCM, and MIN 2B.
and hemochromatosis.
يس هنعمله في الإمبابي ده وهو صغير كده عشان السيروديك.
Hemochromatosis.
Hmm?
What the benefit of hemochromatosis?
Screen, they do screen by 13 for the
You-
relative.
You mean
علشان يديها الأيرون عشان يديها الأيرون
okay.
عشان يديها الأيرون كليشن.
لا عشان just for follow up early يعني early
Yes, maybe
implication.
for also to advise
blood
against alcohol.
blood
Alcohol.
extraction, regular blood extraction. Yeah.
But hemochromatosis will be diagnosed, not a screen. You can be diagnose him with the hematocrit, as you said.
But
Sorry, with
not the
ferritin
gene.
and transferrin.
We screen first by 13, then the gene.
Yeah, if the
The
patient has.
relatives. Yeah.
Yeah,
the
yeah.
relative
For the
first,
relatives, yes. Okay.
Mm-mm.
For the relative, yes. If the patient has.
هو الهيموكروماتوزس يا جماعة autosomal dominant.
No, recessive.
Recessive.
Autosomal recessive.
Recessive.
Yes.
Mm.
Okay. You can also mention Wilson, because Wilson also will affect the
But I
liver.
think Wilson not coming in communication.
Okay.
Hemochromatosis. في one point also, Dr. Bassem,
Yes.
if she ask about screen, I need to know
Wilson.
the.
صح.
Okay.
Also genetic.
Yes, genetic, but it come at young age, and I think it's not common in bases.
يعني إيه؟
Okay.
يعني هو هنعمل سكرين ولا لأ؟
Yes, you can.
Yes.
You can, especially if the patient came with liver disease. But yes, you can.
فين ويلسون حضرتك بتتكلم صح؟
Both Wilson and hemochromatosis. It's the same point, because if the patient is alcoholic, the liver condition might worse with alcohol. So you have to advise him about alcohol. And any chronic liver disease patient, you can do that. Especially hemochromatosis and Wilson. Okay, Dr. Aisha, continue your talk. You said something.
Okay, if she ask about screening, you will appreciate his concern and worries,
Mhm.
and you will give the problem with screening. So no benefit from screen,
Yes.
no any prevention, and also you will talk about insurance. You will maybe affect your
Yeah,
mood
this is
and
it will be
the
harm.
insurance.
Yes. Yeah.
Yes, your mood and life and this insurance.
Yes, exactly.
Okay.
This is the disadvantage also of knowing positive
لو هو
result.
أصر أحوله على جينيتك.
Yes,
Yes,
if he
he's right.
insists,
It is
yes,
his
this
right.
is his right. But not you, the one will take consent. Yes, Dr. Sarah, no need to get the consent by yourself. If he insists, as Dr. Aisha said, yes, I can refer you to the team concerned for that, called a genetic counseling team. They will arrange with you what to do and the steps for screening. That's it. So it's not your concern to do it.
Okay.
Okay,
زي ما
clear?
دكتور باسم هو it is prohibited below 18. Prohibited.
Yes.
Below
Don't
18
do.
you can't screen. Yeah.
Yes. Because this is an adult decision. Whenever they are adult, the son or the kid, he can decide for that. If the mother insists, also you can refer her to the genetic counsel. They are the one also can talk with her about this issue. But don't argue with the patient or the surrogate. Don't tell him, no, it's not your right. Don't confront. Say, as I said, you can refer, and the team will arrange with you this the steps, or they can talk with you about this issue. However, it's not recommended to do it before 18. Okay. Some point in the communication, especially, yes, the patient may be wrong, and his point of view, it's not correct. Don't tell him no, or don't argue with him that it's not your right or whatever. Like this point, no, it's not your right to take decision on the baby or the kid on behalf of the kid. No, you can tell her or you can tell him, it's not recommended. However, whenever you want, I can refer you to the genetic counsel if she insists. Don't tell
For
her
son?
no.
For son?
Yes, for son or for baby. Yes, don't tell her
But
no.
it
This
is
is not your
prohibited.
right.
It is prohibited, Dr.
Yeah, this
Bassem,
is
by
what.
law.
Yes, I
By
know,
law.
but don't confront her. Don't tell her
Not
no. It's not your right. Yes. Don't tell her, no, this is not your right. You don't have the right to do
We will
that.
not tell like that, but we will tell it is
Yeah, this is
prohibited
not.
below the 18.
This is the,
Without details, without it is
yeah, but
not
she
adult or
might.
you can't take a decision on behalf of it. Just we will tell the law prohibit screen for below the 18 for this disease.
Some words like this, Dr. Aisha, will irritate the surrogate. He will tell you, no, I won't. I insist to do. So be gentle
But
while
just
saying these
the
issues.
word not recommended different from prohibited. It is not recommended for all the people, for all relatives, not recommended to screen. But for below 18, it is prohibited. It is, by law, you can't do.
I don't prefer to do this like by force or by law or
I don't know
prohibited.
if it is already in exam. They will ask about this question.
Yes,
I
there
think,
is
they
question
will
like
not.
that. Yes,
Question?
yes, question. Can I do to my kids the screening? No,
هانتنجتون يا
you
جماعة
yes. Any
معنا
disease.
معنا ساعد بنقطة بسيطة.
أهلين دكتور هند. Yes.
احنا عايزين كلمة متوسطة، يعني عايزين جملة في النص بس، مش not recommended ولا prohibited، ممكن كلمة في النص.
طيب
Yes,
هي كلمة not recommended ليش مالك معتبرتيها إنها بالنص؟
لأن not recommended دي it is not recommended but you can ask to do.
حلو،
It
فأنت
is not
بدك
prohibited.
طب أنا
Yeah.
عندي سؤال، أنت منين جبتي معلومة إنه it's prohibited يعني
موجودة على الموقع بتاعته.
هن بالNHS مكتوب إنه if he's below 18
prohibited yes. ده الكلمة مكتوبة كده صراحة في الموضوع ده.
okay.
معلش
But
سوري
أي
the
دي
way
عائشة أي
way
دي
to say this is يا دكتور عايشة, this is the way to say this to the patient or surrogate. He will be irritated more. This
I
is
know
my
but
point.
I try to find intermediate or
أيوة ما لطيفة
something
الكلمة صح حلوة.
كلمة شوية
So
لطيفة بس ما
yeah,
تكونش
she
not
might
recommended.
or she might tell you this is my son. What's the problem for that? I have the right because he's my son, not yours or whatever. So just tell her in good or gentle way, no, it's not recommended to do it now, and we can wait until the age of 18. That's it. But if you said no, prohibited, he will be more irritated and he will argue with you more.
They will insist, yes.
Yes, they will insist. No, doctor, I want to do it now. Refer
دكتور
me
باب
out. Yeah.
يا جماعة صوتكم مسموع ولا
Yes, you can talk. Yes.
نور حاصل؟ بسألكم ديته مرض هيموكروماتوز ولا هانتينغتون؟
Any condition.
لا لكن هنا we're talking
لا لا
about something.
الهانتنج
Any
بس
Yeah,
condition
hemochromatosis you can because it's
screen.
yeah, you can do because you can prevent the complication. But Huntington, no any benefit from the screening.
Huntington and myotonia dystrophic are the same.
The same, myotonia also the same. So the autosomal dominant and
مايوتونيا. طب أنا في المايوتونيا بركب بعمل ECG، بركب لو في هارت بلوك بركب له
if
بيس ميكر
symptomatic.
Genetic screening is not advised يعني.
Yeah, and if symptomatic, you
بيلو
will have the
18 يعني
symptoms
بيلو 18 ولا عموما؟
in general.
يعني
In
أنت you will not encourage the patient or the relative to do
Yeah.
the test.
بص هو لو
because
انسيست يا جماعة نحوله على الجينيتك كونسلنج تيم وهم يتكلموا معاه وخلاص، حتى لو
yes,
هم يعني هم بقى
but
عندهم استعداد
it's
يوريهم القانون ومش القانون خلاص.
لكن يا
لكن ده مش
دكتورة
شغلانتي، أنا هقول له
زي ما قال دكتور باسم في two disease ما في ضروري انك انت تعمل لانه ما preventable.
هقول not recommended as
ما
there
في
is no
حاجة
benefit from
بتتعامل
this.
عشان كده you have يعني انت ما تعملي لهم اي encouragement ولا تجيبي سيرته الا هي تسألك تقول لها نحن we can توريها ال disadvantages والadvantages بتاعت التست زي ما عملت الدكتورة، وبعد ذاك تقولي لها نحن we will refer you to the genetic counselor. لكن في diseases لأنها preventable لأنه في something can be done ده ممكن انت تنكرج التست يعني زي ناس الامراض اللي قالها هسه دكتور باسم دي.
yes, exactly. Yeah.
Yes.
Okay, and the way how to explain Dr. Aisha is very important. It comes in your feedback that you are arguing with the patient or confronting the patient or the surrogates. We are there just to calm them and to talk with them in good and polite way.
You can ممكن تقول لها مثلا as a disease is not preventable and nothing can be done and the tests will make you nervous and مثلا stressful nothing and it can affect your mood.
وأفكت الانشورنس بتاعك وبتاع
والinsurance وكده. I think it's better and
Yes.
he is still young. I think it's better to we prefer
any
to
way to
yes
convince
يعني خلي كده
without
بالراحة
yeah
يعني he prefer
without
to do the
saying
test after he will
prohibited.
decide by
Yes,
himself yes كده بس
yes,
لكن
exactly.
prohibited وكده ما حلوة
exactly.
وبعدين بس
طب
يعني
حضرتك قصدي الهوكم بس والبوليسيستيك صح؟ هما دول اللي هنعمل لهم
ومن
سكريننج.
to A من to B من to B sorry من to B
والهيموكروماتيزس كمان والهيموكروماتيزس برضه.
وهيموكروماتوزيس you can add it yes.
بس الهوكم بيبقى ايه؟ بيبقى بالايكو صح؟
وتقريبا هو
الهوكم
ده اصلا الوحيد اللي
ايكو
موضوع السكرين ده فيه
ايكو.
مشكلة، عشان كده هما بيجيبوه في الامتحانات. هو
yes
الهانتين الوحيد اللي انتي ما بتعمليش سكرين بتهيألي.
exactly
ما
yes.
سمعتش اي حاجة تانية
والميتونيا
ما
ديستروفي
بنعملش.
الميتونيا
في
لا،
الميتونيا
موضوع
also
ديستروفي
ميتونيا دوت عايزين نسمع
no
عنه
there is scenario ميتونيا
برضو
congenita
بس
وميتونيا
الميتونيا
dystrophic
فيها
ما
حاجات
yes.
بنعملش
ممكن
سكرين.
تبريفنت.
no need for screening. I have scenario for myotonia congenita
هو برضو
ومyotonia
اوتوسومال ريسيسيف ولا
dominant.
دومينانت؟
dominant dominant
Okay, we can do this myotonia in another day, okay?
بس
Dr. Basim, how to explain degenerative or neuronal loss
breakdown.
breakdown أيوة thank you.
بس
Okay.
انه موضوع البروهيبت
معلش.
دكتور الهوكم والبوليسيستيك الاثنين بالالترا ساوند صح؟ يعني ده بالايكو وده بالالترا ساوند بس
Yes,
لكن في
exactly.
جينيتك
Yes. Yeah.
وهنا الهانتنجتون we will offer genetic testing we will not offer genetic testing and if he asks for genetic testing بس we will explain about the advantage and disadvantage
Yes,
صح كده؟
exactly. Yes.
طيب اوكي
Okay,
تمام.
دكتور هند.
بس سؤال
Yes.
الدكتورة اللي قالت عن موضوع prohibited، يعني بس لو تكرمت، لاني انا عن جد الفترة اللي غبت فيها حاولت ادور انه عن جد كاتبين prohibited قبل ما اني اتناقش معها، فما في ولا يعني. هلا شوفي حطيت NHS، حطيت الجوفرمنت تبعهم تبع GMC ويب سايت، ما حدا كاتب prohibited. فكلمة not recommended يعني أنا بس حتى أقنعك فيها لأني حسيتك بنوب مالك مقتنعة. ترى كلمة not recommended is the best word، لأنه هن ما بيحبوا إنك أنت تظهري بمظهر الواثق 100%. يعني كلمة prohibited يعني you will never do، you will never allow you. فأنت بالcommunication واحدة من السكيلز اللي بدهم يعرفوها فيكي إنه you don't give a definite answer. always you need to ask your senior، always you will refer. دائما في نوع من الكوميونيكيشن بينك وبين البيشنت لحد ما يقتنع. فإذا أنت قريتيها بمكان شاركيها معنا بس لحتى نعرف إنه فعلا هو prohibited، لأنه أنا اللي
تمام
بعرفه إنه it's
تمام.
not it
بس
is
you are
not
right, even it is I know this is strong word.
لا مو موضوع
Okay.
strong word، بس يعني انت ما قريتي، يعني ما في ولا source كاتب لك، لانه نحن في situation نعمل لهم genetic screening. انا حتى يعني حرام، انا شايفتكم كثير منسجمين بالحكي، بس مثلا لو انا جاي وعم بقول لك ابني بده يطلع طيار، ونحن عنا history of Huntington، وهي will join مثلا armed forces، ولا will join as a pilot بعمر مثلا ال 16، هن بتخرجوا ترى ابكر من عمر ال 18 من الثانوي، فوقتها you will have to do for him genetic testing. تمام؟
ليه بقى؟
لأنه في ريسك
ليه؟
على his life.
بالعكس انت كده هتضيع اماله. طب ممكن لحد
لا
30 40 سنة ما يظهرش عنده.
لا أنا I will not let him يعني I will do it for him to save him، لأنه إذا عنده الجين حرام ما حيدخل. فدائما
مين اللي قال ان هو مش هيدخل؟
education
هم هيعملوا له سكرين؟
هعمل له سكرين طبعا، لأنه إذا طلع عنده الجين وهن عندهم family history he will not go for armed forces ولا حيطلع
هو
بايلوت.
الارم فورسز بيعملوا حاجات معينة، لكن هم ليهم
وبعدين
الحالة
لا
الصحية
تنسي كمان،
دلوقتي
ولا
هم
تنسي
اصلا مش
كمان
هيعملوا له
عندك
مالهمش دعوة.
anticipation وعندك anticipation، يعني حيطلع هو بإيش أبكر.
ماشي، بس
يعني
هم ليهم
أبكر
الحالة دلوقتي. ممكن واحد عايز يعيش 10 سنين بأماله وبطموحاته، يعني فاهماني؟ هي القصة مش كده خالص طبعا.
انت بتعطيه الاوبشن، لانه هي جايه تسال عن جيناتيك
ماشي، بس هو هياخد
سكرينينج.
decision upon on one لسه still
هو
not
بده
mature to
يفوت
take the decision.
حلو. انا
فاهماني؟
في شيء اسمه، انت كثير عم تفوتي بديتيل، في شيء اسمه جيليك competence. جيليك competence هو person less than 18 و he can give a consent. واحد عم بيقول لك انا بدي فوت بايلوت، هذا كيف بتقولي عنه non competent لانه بس عمره 16؟ هذا competent you can bring him و counsel him وتقولي له ترى انت عندك ريسك، يا بكمل بيقول لك ايه انا مستعد اني to take this risk، وبينحكى انه هو عنده this genetic risk، بحب يكمل ما بحب يكمل، he is allowed to continue he is not allowed. لكن أنا بفكرتي اللي بدي أعطيك إياه الأوبشنز مفتوحة، ما في شيء اسمه
يعني هو
prohibited.
النقطة عامة إن إحنا متفقين عليها، هي الكلمة
أيوة
فعلا
حلو،
ممكن تعمل
الأوبشنز
أرجو
مفتوحة، مو
وممكن
إنه
تعمل
إذا أقل
مشاكل
من
مع
18.
السيروجيت، فبلاش أقولها وخلاص وريفير هيم وخلاص للهيئة المسؤولة عن الكلام ده. تمام.
حلو، إذا أنت عملتي له referral لأنه في discussion can be done on this issues، يعني ما في شيء اسمه it cannot be done أو he is not allowed to do it. يعني حتى مع الجيناتيك دكتور لو هو حكى معه في conditions you can screen those people. فأنا
لو عنده
دورت عشان هيك،
symptoms. أيوه.
حتى لو ما عنده symptoms، لو في
لو
شيء
عنده strong family history، لو عنده كده ممكن يعمل التست يا
ممكن
دكتور.
يعمل، لأنه في ناس كتير بيكون في عندهم conditions معينة بحياتهم، يا بيتجوزوا بكير، بيكون في عندهم مثل
لا
ما
مش
أنت
قصدي، يعني قصدي أنا بتكلم على الديزيز دوت، يعني هو
حتى
الديزيز ده
بهذا
بالذات
الديزيز
ليه
حتى
ليه
في له indication
تمام.
to
هو
screen
عامة
before
احنا
80.
يعني متفقين على نقطة إن احنا مش هنقول
انتوا
الكلمة دي
متفقين
بغض النظر بقى
بالمناسبة
عن
انتوا
ايه
to
الصح
to
بالظبط.
refer to the genetic testing.
ده مش قصتنا.
لأنه شوفي أنا ماني زعلانة، بس لأنك أنت حكيتي كلمة، قلتي إنه كلمة not recommended معناتها there is a possibility he can do it، وأنا هذا اللي بدي أوصل لك إياه، إنه يس
ايوه،
صح.
انه ما تخليها مقفولة، خليه
ايوه، وهذا الشيء فعلا
موارد.
موجود. يعني مو لانك انت استعملتي كلمه not recommended، لا فعلا في ناس indicated، في ناس indicated to be done. فكلمه prohibited من الكلمات اللي حتسد الطريق، وانت لا بالعكس ما بدك تسدي الطريق. و not recommended is a very neutral word، والجيناتيك مثل ما انت قلتوا counseling is there. انا بس لانك قلتي انك قريتيها بالموقع تبعهم
يعني
فهمت
هم
شو
انا
قصدي.
قريتها طبعا، هدور عليها واجيبها لكم، بس هي النوت
هذا شيء
ريكومندد يا
ثاني، هذا عن
جماعة
جد
زي
اللي
ما قلنا.
خلاني اتناقش انا
علشان
وياكي
ايه؟ عشان هي
انك
ضارة ليك، عشان هي ممكن تأثر عليك. فلو احنا بنقول الكلام ده برضو بالنسبة للطفل فده مش حقيقي. يعني احنا
Okay,
دي
let's talk.
تمام.
By the way, another issue. Dr. Hind remind us about screening for autosomal dominant earlier. You can also, when the patient decided to donate, or of course he will not donate before 18, but also this is another issue to do screening by genetic testing if the patient
ترى حتى
hasn't.
الدونيشن، أنا مستغربة منكم. ترى الإيج أوف كومبتنسي بيختلف حتى بين الدول، مثلا بأيرلند 16، بيوكي 18. ففي ناس
مظبوط. أيوة.
يعني إذا أبوه على الليستة وهي gonna die you don't have only a donor، بالأي بي كي دي عادي فيك تعمله أقل من سن 18. وإذا إذا الطفل أو اللي هو أقل من سن 18 he's competent enough ليفهم عليك، ومثلا he can give a decision he can donate to his father. أنا حأعطيك فكرة، يعني هل هو بيرضى مثلا إنه أبوه يتوفى لأنه هو لسه عمره 16 وحنستنى سنتين ليصير عمره 18؟
لا طبعا،
أنا بعطي
always there is exception دكتورة.
ايوه عليكي نور. فانت دائما يعني، بس انا اللي بدي اقول لك قبل كل كلامي انه لو انت عندك السورس، يعني انا هذا اللي بدي اياه، لانه عن جد لو انت عندك سورس we will take it in account. وانا عن جد دورت هيك، غبت 3-4 دقائق لانك انت قلتي انك قريتيها، فدورت على كلمه prohibited او completely contraindicated بهالمعنى فما لقيت. فلو عندك السورس شاركي حتى عن جد نحن نستفيد. والعلم يعني الشغلات اللي انا بعرفها عن هالموضوع حبيت اقول لك عليها لانه it's not يعني up to my knowledge it's not prohibited و there is
Nice,
always
appreciate it والله يا دكتور هند.
exceptions
شكرا
يعني.
جزيلا.
تمام.
appreciate.
Okay, thank you all for the discussion. Let's move to the long. Dr. Abdullah and Dr. Aisha.
Okay.
Who will
If
start?
دكتور
Assalamu alaikum.
Alaikum
Yes,
salam.
I am ready.
You can post your case.
Okay.
so I'll be the candidate first, yeah?
Yes.
Okay.
I have asked a question about genetic counseling about Hukam. Just meanwhile, I'm posting the case, but if you can anybody answer the question, please.
Yeah, post the case, then we will receive your question. Okay, 65 years, Mrs. Lisa, with complaint of chest pain. Respiratory rate 18, saturation 96 room air, blood pressure 140/70, heart rate 80, temperature 37.5. Dr. Aisha, 2 minutes, then we'll start.
Okay.
Your question, Dr. Abdullah?
In Hukam, if we have a scenario about discussion about genetic counseling, so
yes, you can offer it.
Not okay.
بس
but
إلها indication. يعني genetic testing in Hukam it has indication. كان منها malignant family history. مقصود بmalignant يعني family history of death. يعني لو جاب لك بالسيناريو his brother has died there is a possibility إنه his brother died of مثلا heart disease. ف you will really refer، يعني حتى ما فيك تقول it is not recommended. فوقتها you will refer him to the genetic counsel to explore whether you are candidate. بس هذا طبعا امتى؟ لو طلعت الايكو نيجاتيف.
Yes, after risk, yes.
يعني انت اول شيء يعني بالنهايه حتى اللي عندهم indication for genetic testing they are only gonna go through this pathway لو انت حاليا ما قدرت تثبت انه هو في عنده evidence by echo، طلعت الايكو equivocal او طلعت negative. فلو هو عنده malignant history he is going to be a pilot، ولا حيجوين ال armed forces، ولا حيجوين ال heavy الجوبس اللي فيها heavy load. تمام، مثلا athletes بايلوت بالارمي فورسز بالاشياء الريسكي. وعندك كمان كان في indication ثالث، استنى كانوا 3 indication هدول الموست كومن: malignant family history و heavy load او heavy heavy
Yes, the job,
demanding
the pilot, and
الجوب
the
مو
job.
بس بايلوت، يفضل انك تقول heavy demanding job
Okay,
او
risky
demanding
job.
heavy
Mhm.
demanding job. هذا مصطلح بيشمل أشياء كتير حتى نحن ما لنا علاقة فيها، ممكن تكون ما خطرت ببالنا يعني. فهيفي ديماند مثلا مثل ماشين، البيبول اللي بيشتغلوا بالمصانع على الماشين، ماشين اوبريتور، ما بينفع يشتغل واحد عنده هوكم بماشين اوبريشن، ممكن يجي اريثميا باي وقت او شوك من الاي سي دي. تمام، فهي اسمها هيفي ديماند جوب. هيفي ديماند جوب هي usually we don't like them to do it يعني. والمالجنانت فاميلي هيستوري، وكان في indication ثالث إذا نسياني والله، إذا lady gonna become pregnant.
Arrhythmia,
آه
arrhythmia, sustained vitaco.
ايوه هو سيمتوماتيك، الطفل نفسه سيمتوماتيك او
شوفوا
الراجل نفسه
هلا، شوفوا
سيمتوماتيك.
دائما بدكم تفرقوا السيمتوماتيك، ما في داعي تحفظ الانديكيشن فور جيناتيك تيستينج، لأنه السيمتوماتيك هذا اوتوماتيك
Already, yes,
عليك
encouraged.
نور. فأنت لما بتقول كلمة سيمتوماتيك فأنت دائما بتحط أي ديزيز سيم، سيمتوماتيك واسيمتوماتيك. وقت بنحكي على انديكيشن
Mhm.
اوتوماتيك نحن عم نحكي على indication of
Yes.
asymptomatic. فما يعني ما تحطوها دائما كانديكيشن، لا هو يا symptomatic يا asymptomatic. symptomatic we do for them echo، ولو الايكو negative we will look for genetic testing إذا عندهم family history، لأنه this patient might have something. هلا عم نحكي على patient asymptomatic جاي لعندك لا palpitation ولا أي شيء بالحياة، هذا اللي لازم تحفظوا الانديكيشن تبعه. ثواني نشوف إذا بنقدر نطلعهم، لأنه هن عن جد بالهوكم بيهتموا بهذا السيناريو أكثر من غيره، الانديكيشن اوف جيناتيك تيستينج، لأنه في له انديكيشن معينة. malignant family history، symptomatic or suspicious radiological feature. symptomatic or suspicious radiological feature، symptomatic خلص عرفنا مين هو، بس لو في واحد عنده suspicious radiological feature وما عنده family history، يعني ابوه وامه مثلا او اخواته ما كان، يعني هو ما بيعرف شو صار فيهم، وانت عملت له ايكو لقيت في suspicion بس you couldn't confirm it. فمثلا عنده adverse complication related to هوكم، يعني arrhythmia ما بتجي غير مع الهوكم. participating in competition sport قلناها. و other complication، وعنده left ventricular hypertrophy، يعني واحد عنده asymmetrical left ventricular hypertrophy او عنده هوكم complication وما عندك family history، يقول لك هل هدول suspicious echo feature هوكم ولا لا. هذا indication for genetic testing، لأنه عندك echo feature they are not confirmatory 100% وما عندك family history وجهك. تمام، هذا واحد. 2 malignant family history، يعني family history of sudden cardiac death. 3 high demand job. حلو، هدول هن ال3: suspicious echo feature، malignant family history، طبعا suspicious echo feature without family history، وmalignant family history وhigh demanding job.
Yes.
تمام، 3
Okay.
indication. فأنا
السيمتوماتيك ما داخله في الانديكيشن. سيمتوماتيك
السيمتوماتيك
Symptomatic already
شوفي،
here. Yeah.
ايوه هذا لحاله، انت ما
Candidate.
لك
Already
اسميهم
candidate. Yes.
already candidate by
I
all
think the
means.
doctor asked the question. He is not an Arabic speaker. Sorry, he is an English speaker.
Sorry. طيب, I will repeat them quickly that we have 2 categories when we talk about HOCM. We have category symptomatic. This is by default is an indication for echo for if echo whatever it is like suspicious, we can go for genetic because he have symptoms. I have to look for the cause of symptoms. Now we're talking about asymptomatic person who came to you asking about HOCM, but he don't have any palpitation, no chest pain, no syncope, nothing. This guy, you have to look in his family history. If he have a malignant family history, which means family history of sudden cardiac death, and you did for him echo, and echo is negative, you will do genetic testing, first indication. Second indication, you have a suspicious echo finding, okay, in the patient, and there is no family history. So you will go for genetic testing to prove whether those suspicious features in echo are related to HOCM or not. I mean by suspicious, it means not confirmatory, and there are echo criteria. So some patients, they don't fulfill echo criteria, but they have what we call suspicious feature and no family history, which can guide me that those suspicious feature in echo could be HOCM. At that time, I will do genetic. Third one, patient who gonna apply for high demand job or high demand sport. This is the third indication. And for sure, this guy who is going for high demand job or high demand sport, he have a family history. That's why he's scared that he might not be candidate for this job or he might not be candidate for this type of sport. So you will have to do echo first. If echo is negative, you will go for genetic testing. My main point that echo is always there. Echo is always there, even when the patient is indicated for genetic testing. And only when echo is negative, those people are candidate for genetic testing. Otherwise, normal population, patient who don't have malignant family history, no suspicious feature on echo, he's not into a high demand job or high demand sport. That guy, if his first echo is negative, if you remember the schedule, you will enroll him in a schedule to be screened after 2 or 3 years. Okay? And you will tell him, so if he told you, doctor, what if my echo is negative? You will exclude all those indications. And if they are all negative, then simply you will tell him, we will schedule you for another echo, which will be done according to his age. From 10 to 13, it is every 3 years. I remember from 13 to 20, every 1 year, which is the age of puberty, the highest peak. And from 20 up to 60, when the chance of the disease is less, in some sources, from 28 to 60, you can do it every 5 years. Okay, so you will schedule him if he don't have indication and if his echo is negative. Okay.
Okay, thank you, Dr. Hind, for the clarification.
Thank you,
You
Doctor.
are most welcome.
Thank you. Okay, let's go to the lung. Ready, Dr. Aisha? Let's start.
Yes, start.
Okay, timer started.
Yes.
There you go.
Okay, hello. I am Dr. Mutwalli, the doctor in this facility today. May I confirm you are Miss Lisa, 65 years?
Yes, I am, doctor.
Okay. I am here today, Miss Lisa, to discuss about your health condition, and may I examine you? Is this okay with you?
Yes, sure.
Okay. Can you raise the voice, please?
Yes, sure.
Okay. It came to my knowledge that you coming today with some problem in your chest. Can you tell me more about that?
Yeah, doctor. Actually, 2 weeks ago, 1 week ago, this pain started. And actually, I had an operation for discovered lung cancer 3 weeks ago. Removal of a lobe in my lung, part of my lung. But that's not, I don't think it's related to my pain. The pain started after 2 weeks after that surgery, which is 1 week ago.
Mm-hmm.
Yeah, it's in the center of my chest.
So this pain started 1 week ago, and you have this operation 3 weeks ago.
Yeah.
So about your operation, Ms. Lisa, it is went good. No any event at it.
Well, there was, they say, air collection, which is pneumothorax after the surgery, but they did everything well. They did the tube in place and they sucked that air, and I went discharged well in a well condition. I don't think they did a very good job there. My pain is different now. It's in the
Yeah.
center of my chest. It's really bad pain.
I'm sorry for that, and I'll try to help you, Ms. Lisa. So, do you know the operations that you did? Like you remove part of your lung.
Yeah.
Which part you did?
Lift up.
Left upper part. Left upper part.
Yeah.
And any medication after that you recommended for?
No, they just
like chemotherapy or radiotherapy?
No. They just want to discuss my case later on, and they didn't start anything for me.
Oh, okay. And this pain, can you explain more about this pain? You said that it's central pain.
Yes, it's in the center of my chest. It's really bad, 10/10.
So it is the baddest chest pain you have ever.
Yeah, awakening me from sleep. I can't.
Sorry for that.
Yeah, and it's sharp pain.
Sharp pain, and it is start suddenly 1 week ago, and increasing, or it is gradually increasing.
It's you can say gradually worsening. Yeah, since it started.
Okay, and it starts in the same place, like central.
In the center of the chest, it goes to the left arm sometimes, and the neck.
Yeah,
I can't lie down with this pain.
I'm sorry for that, Ms. Lisa. Do you need any help right now, like any painkiller?
Oh, no. Well, yes, if you could. Thank you for that.
I'll offer that. Okay.
Thank you.
So this pain, you can't sleep with it. So you feel good when you sit down or bending forward?
Yes, I am.
Okay. And you feel this pain associated with some shortness of your breath?
Yes, you are right.
And if you take deep breath, you feel that pain worse?
Yes, you are right.
And this pain also any cough with it?
No cough, no.
No cough. Yeah, okay. And also, you said that this pain maybe reached to your shoulder.
Left shoulder, yeah.
Anything else like the back? The pain is associated with pain also at the back? Like you feel it's
no,
also
not
at the
exactly.
back? No, and your jaw, your neck?
Yes, to the neck and the left shoulder. Yeah.
And your jaw? No.
Yeah, like in the same area, the neck and the jaw and the left shoulder. Yeah.
Do you notice that when you trying to walk or doing any activities, it is increasing?
Not really.
And if you rest, you feel better or something more comfortable, or no relation?
No relation.
And do you notice that it is associated with also swallowing, like when you eat, it is increasing or something like that?
No, not related.
No. Okay. So can I ask you if you have any high temperature?
Yes, sure.
I found that in your chart.
No, I don't have.
Okay.
The same chart, no temperature.
Any dizziness with this pain?
No dizziness.
Any swelling in your limbs, your leg?
No, I didn't notice any.
You notice any rash or skin changes?
No.
Okay. You don't have cough or coughing any blood? Yeah?
No.
You have any like heart racing?
No.
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 Okay. And do you notice that this pain Awareness of your heartbeat?
No.
Okay. And apart from this operation, do you have any medical condition in the past?
No, not really.
So you're not diagnosed with any disease in the past?
Just this lung cancer.
Okay. Are you on any medication right now?
I am on aspirin, atorvastatin, and I am on ibuprofen. Well, yes, doctor, I had some heart attack and they did a heart catheter and they said mild disease of my heart vessel.
At what time this happened?
5 years ago.
5 years.
They put me
And-
on aspirin.
Okay, okay. No other things or medication you
No.
are on. And this
No.
medication you started from this 5 years
From the
ago. And
yes,
the
yes.
ibuprofen, you take it after the operation?
Ibuprofen, I take it after the operation, yes.
Okay, okay. And any other surgery in the past?
No.
Okay. Did you travel anywhere this week or these weeks?
No, I didn't.
Okay, okay. What do you do for a living, Miss Lisa?
I'm not working at the moment.
And about your daily activities affected, I think, by this problem?
Yes, very much, doctor.
Okay.
I
Do you need any
can't
support or do you have
finish.
anyone at home who can help you?
Hopefully, yes, doctor. I hope that you know the root of the cause of my pain.
So
I'm
with
afraid
whom you
that I
live?
have this cancer again.
I appreciate your worries, Miss Lisa. I'll try to answer your concern by end of our meeting. So with whom you live,
Thank
Miss
you.
Lisa?
Sorry?
With whom you live?
Oh, I live alone.
Okay, I'll try to support you as much as you can, and I'll refer you to the social health worker. They can see how they can help you. And do you smoke,
Thank
Miss
you.
Lisa?
No,
Okay, do you drink alcohol?
only weekends.
Okay. Do you have any family history of note that I should be aware of?
Not relevant, no.
Okay. Any weight loss you notice or weight changes?
No,
Okay.
no.
Okay. Any lump you notice in your body?
No.
Okay. Okay. I need to examine you, Miss Lisa.
Okay.
Okay. I'll first see the local observation if there is any buffness or any edema. No.
No, normal
Any congestion in
appearance.
the face?
Normal appearance, no.
Normal appearance. Okay. I'll see the pulse in both sides.
The same
It
as
is-
outside.
Okay. I'll also I'll offer that I need to know the standing blood pressure. It's the same.
It's no need, yes.
Okay, okay. I'll see if the patient pallor in the eye, if any pallor.
Not pale.
Okay, I'll examine the neck for any for jugular venous pressure if it is congested, and I'll ask if there is tummy pain, and I'll try to
It is
base
normal.
on epigastric. Okay, normal. I'll also notice any lymph nodes in the neck. No.
Normal.
No, normal. Okay. For also, I'll open his mouth to see if anything cyanosis, any ulcers, any
Her mouth.
infection.
Yes, there is no ulcers.
Okay, okay. Then I'll examine the chest. I'll auscultate the heart and I'll detect the apex. There is any muffled heart sound?
Apex is normal place.
No muffled
Under
heart
place.
sounds.
You hear the S1 and S2 clearly.
Yeah, okay. No any rope. I can hear. No any murmur.
No.
Okay. I'll then after a heart auscultation abnormality, I'll auscultate the chest bilaterally. I'll expect that the upper left part will reduce air entry. Any other thing abnormal?
No, the same. There's
No,
nothing specific in
And the
particular.
expansion of the chest is normal?
Is normal, yes.
Okay, okay. Then
With just
I'll
little reduced, mildly reduced left side, as you said.
okay, okay. I'll see the lower limb, any edema?
No.
Okay, okay. I'll also feel the dorsalis pedis artery. It's okay, intact. Okay. No any
The
skin
pedis
rash
is intact.
noticed or erythema? No.
No.
Nothing. Okay. Okay. So you have any like being sick or throwing up?
No.
Any throwing up blood anytime?
No.
2
Okay.
minutes remaining.
Any pain after that when you eat or any tummy pain?
No.
Okay. So what's your concern, Ms. Lisa?
Yes. Doctor, what do I have?
Okay. I
Is it
appreciate your
serious?
concern, Ms. Lisa. From you told me and after I examine you, most probably you have condition that called pericarditis. Don't bother about the name. It is like condition that you have some soreness and a problem in covering of your heart. This may be related to the recent surgery that you have, and I reassure you that is like a benign condition and we can treat it with some medication, but we need to observe you more and we did some tests for you, so we will mark the covering of your heart if there is any like fluid or any air also in your lung like happened in after the surgery. So it is also possibility in your condition to be the cause is air around your heart. It is okay. Are you follow me?
Yeah.
Any other concern? Anything you need?
Will this go away?
Yes, most probably it will. We will manage the condition. It can return back, but we will keep following you and observing you. Don't worry. Any other concern?
Is this my cancer coming back?
We need to investigate that, but most probably I think if you get surgery for this cancer, so it is in stage that you will not have the cancer more rapidly or in shorter time like that.
Okay, time up.
Okay.
Yes, time up.
Can you please summarize the case and give me your differential diagnosis?
Okay, this female patient, 65, Ms. Lisa, she presented by chest pain for 1 week. It is like sharp central pain, increasing with breathing and increasing by lying a bit. It is also had some relief by leaning forward. It is also more bothering with cough. There is some shortness of breath associated. She has history of operation of upper left lobotomy for lung cancer 3 weeks ago, that complicated by some pneumothorax that is managed correctly, and he has no residual and he discharged with good health. By examination, I didn't find any positive sign for any red flags for this patient. He has also history of heart attack in the past 5 years ago, but he is regular on aspirin and statin till now.
She is female. Okay.
Sorry.
Okay. What red flags do you mean?
I mean by it is that it's not chest pain that is like associated with exercise and relieving by rest. Also red flag for any vomiting blood, for any bleeding. Also red flag for heart racing, for any lymph nodes, and any arrhythmia I can found on auscultation, any reduced air entry or like reduced chest expansion by examination.
Okay. And do you how you will investigate? What is your differential diagnosis first?
Okay, my differential will be more wide, but I'll put pericarditis and hemothorax or pneumothorax, or also pericardial effusion in the top. Then it can be also like ischemia, and it can also be like peptic ulcer or gastritis. It can be also muscular pain or strain of muscle. Also, we can put in it infection.
Okay. And what are the how you will investigate first the patient?
I'll admit this patient till the investigation. I'll do first chest X-ray, then I'll do ECG. I'll make also for him blood gases. I'll make bedside echo. I'll then do some basic investigation for him, and I'll include IMR, CBC, and also troponin and liver heart enzymes. I'll do blood gases, and also I may need to do CTBA for him, and
Good.
also we can do like I can't remember the name, but we can, if there is any effusion around the heart, we can aspirate and send for test.
Okay, good. What are, do you know any indications of admission?
For this patient, he is in real pain. His pain is scoring, and he is at risk because he's post-operative, and he is ischemic before, has before heart attack before. Giving her age and his history, I need to admit this patient.
Good. What do you
and
think?
She is on me also on aspirin and ibuprofen. I also need to examine her blood, yes, if bleeding tendency.
Okay. And how you will manage?
I manage this patient if as acute patient. We will stabilize the pain. We will see if there is any stress. We can give oxygen. I'll include in my team, multidisciplinary team, including the cardiothoracic surgery and the cardiologist and the pulmonologist. I'll after the basic investigation, if there is any possible pericardiac effusion or something, we can aspirate. Also, if there is pneumothorax, we need chest tube. If it's infection, we'll start the antibiotic.
So echo found a small effusion around the heart, pericardium, and the team decided to by cardiology to start something. Do you know any medications that can help the patient?
For this patient, I think the anti-inflammatory non-steroidal or steroid, it can be started. Also, if possible, infection suspected, we can start broad spectrum antibiotics. For this patient, if there is congestion or signs of heart failure, we can give diuretic also or dilator like beta blockers. I think this, yeah, is all.
Okay. Okay. Thank you.
Thank you, Dr.
Okay, Dr. Abdullah, you can comment. Thank you, Dr. Aisha. Well done. Let's hear Dr. Abdullah comment.
Thank you, Dr. Aisha. Yes, you have analyzed the chest pain, central with radiation, and it's sudden onset, pleuritic, better with sitting up, and here you got the diagnosis. Shortness of breath is not typical. They shouldn't start. They shouldn't have shortness of breath. Actually, here as something herring, red herring. It's like a distractor. The shortness of breath could be from the pleuritic pain nature. It's unexplained. The patient doesn't have fever. Important question. Any weight changes, weight loss especially, lumps or bumps, very important. Any should screen. So here's the constitutional symptoms, and then you'll ask tiredness. You'll ask if did you have anybody not told you that you are paler than usual. First, should finish all the cardiovascular. Do you have any shortness of breath while? Do you gasp for air while you are sleeping at night? Recently, did you have? Do you notice that you are requiring more pillows to sleep at night because of the shortness of breath? And is there any cough? And is there any lower limb swelling? And is there any coughing blood? And screening for any reduced mobility recently, especially given the patient has cancer, you should ask about DVT, any one leg swelling. And then you have asked nicely, you screened about rheumatology and any joint pains, any skin rash, spots or pigmentation. You should ask about dryness in the eyes, mouth, any mouth sores, any photosensitive rash, and is there any, you asked about problem in swallowing, difficulty in swallowing, and then you need to ask about any soreness in mouth or joints or private areas. And then you focused about other reasons of this pain, which is good. You can screen for that any other area on the body you have with the pain. And then you have asked about, you ruled out if the pain is coming from the stomach or from the chest, with any infection possibilities, and if there is any problem with this after meals, for maldigestion or acid feeling or burning in the stomach. And then going to the past history, you didn't detail about which type of cancer in the lung that was. You asked about the complications, that's good. And did you ask about, was it metastatic, was it spread or not? It's very important. So it wasn't spread. It was in early stages. The patient may tell you about this information. And there was mild coronary artery disease in the years in the past. Going to the medication history, nothing significant, just aspirin and lipid lowering agents and painkillers. Illicit medications, and then going to the you didn't explain about the obstetric history here, obstetric and whether the past oral contraceptive use in the past, and any previous complicated pregnancies or any lost pregnancies. You asked about the travel. You asked about the job. You didn't ask previous jobs. Okay, and then going forward to the examination. Here you will have to focus on cardiovascular and the chest. So almost not enough time. And it's straightforward, I think. Examination findings, nothing in the patient, pretty not significant findings, just the scar and the reduced and the evidence of the lobectomy.
Yes,
so here, so the peripheral, you said yes, acute pericarditis with possible pericardial effusion. This is very important, but you should offer, very importantly, you should offer check to confirm the vital signs, to rule out. You should mention cardiac tamponade. I should rule out that, at least in the discussion. So I should be aware that there is negative sign, there is negative pulsus paradoxus, and there is negative
I think it will be jugular venous congestion. Yeah.
JVV.
And it is negative, yes, in examination.
No, there are two important signs. You mentioned specifically you want to rule out the muffled heart sound.
Hypotension.
I also mentioned the high blood pressure
Cosmal sign and pulsus paradoxus.
What is cosmal sign?
So cosmal sign
with the asthma or tension pneumothorax.
Cosmal sign in any it's a in asthma is one of the differential diagnoses. Any condition making an affection of the pressure over the JV over the right side of the heart. So the patient, when he inspires or she inspires air, the JVB normally reduce if it is raised. This is normal. But what is not normal is that it persists with taking breathing in. This is the I think the cosmal sign, and it indicates the I'm not sure actually. There is a difference between the constrictive pericarditis and the cardiac tamponade.
I guess cosmal side, yes, will increase intrathoracic pressure. Like asthma, severe asthma. So the pressure, intrathoracic pressure will be high. This is different than pericarditis. It might be positive with pericardial effusion, not pericarditis.
Yeah, and so it should be put in discussion because this patient could have pericardial effusion, some pericardial effusion, or we don't know, and since you are discussing about pericarditis. I'm not sure. So it's not sensitive. If it's not very specific sign, but it should be put in discussion. So in tambonade, which is more common? How to differentiate between tambonade
الكوزمو
and
ساين common in tamponade. البلسس بارادوكسس common in pericarditis. Yes, true. You are true.
No, I think you reverse
Cosmally,
them.
cosmally in
Now
tamponade. No. What you say?
Pulsus paradoxus in tamponade. Makes sense because it's making more pressure over the right heart. It's pressure effect. Constrictive pericarditis. Oh, sorry. Pulsus paradoxus in tamponade. Cosmal sign in constrictive pericarditis. Cosmal sign.
Share difference, guys.
Cosmal sign in tamponade.
Constrictive pericarditis more common. They are available in both conditions, but which is more and which is more? You get my point? So there is important question. Do you know any surgical benefit later on? What is this condition recurrent? I don't know if this is. It may not be put on discussion by examiners. I'm not sure if this topic is brought in diets either, but I think it's not a bad topic. So there are medication. They may do. There is criteria actually for acute pericarditis. This is important. There are 4 components of the criteria. It's easy to remember: ECG, echo. So typical ECG findings of widespread ST elevation and saddle shaped. 2 is echo findings of suggestive of pericarditis, such as what we are talking about is if you see any type of fluid inside the pericardium, so pericardial fluid. It doesn't matter the amount. 3. So what matters is the speed of collection of the fluid. So you may have a moderate amount fluid, but collected over slow time so it doesn't make a huge hemodynamic compromise of the patient. But if small amount collected like quickly, that may affect the patient, I think. So 3rd criteria is the chest pain. So typical chest pain, as in this patient. And there is a 4th criteria. اللهم صل على النبي. ما أعرف ليه نسيتها. ECG, echo, pain. And there is 4th
I think
criteria.
the vital signs يعني لازم واحدة فيهم
No.
تكون vital sign. Not a vital sign. If he has hypotension, if he has tachypnea,
No. It could be stable. Pericardial rub. Pericardial rub is one of the 4th criteria. Okay. So what other medications can be? So ibuprofen, I was awaiting you to say colchicine. Colchicine combined with ibuprofen, this is the recommendation now. Combined, they are, this combination is recommended. The dose is different. The colchicine dose is different according to the weight. So could be OD, could be BD, 0.5 milligram BD or OD. If above 70 kilo or less than 70 kilos. Yeah, that's what I know. And for short time duration and then for follow-up. I'm not sure then what can we do. It depends on the resolution of symptoms. but if did not resolve, I'm not remembering that. Yes, that's about the topic.
Okay, thank you, Dr. Abdul.
Thank you.
What scenario? Okay, I'll put my scenario, okay?
Okay.
Okay, it is in
Okay,
message.
طيب, what is the differential for your case,
Yes.
Dr. Arifa?
So this is acute pericarditis. So could be malignancy induced related. This is very most likely first. Second, could be the surgery as a trauma related, then other differential of acute pericarditis, such as other than the malignancy here, there is other reasons of idiopathic pericarditis if no reason found. Other use, you can say autoimmune, but I couldn't see any stigma or any features of autoimmune signs or symptoms in this patient like that.
Okay, thank you, Doctor. What about pulmonary embolism and pneumothorax and
No, if it's I think it's better to discuss it as an acute pericarditis case because the pain is so typical, rather than
it's a pleuritic
because
pain.
you don't.
Pleuritic pain. Pulmonary embolism also pleuritic pain.
Yeah, but well, yes, to be safe also, it should be put on the differential diagnosis. Yes, you are right. To be safe,
Because
yeah.
it is a
To tell the
serious.
examiner you are safe, yes. And it is
Yes.
serious condition, yes. You are right.
طيب دكتور عبد الله في الاكزامينيشن سألت قاعد في رب قلت لا ما في البريكاردي الرب مش بتاع الكونستريكتيف بريكاردا تحت البريكاردا.
Yes, but it's not necessary for all the signs to be. So in this patient, there are 2 signs from 4, so it is possible.
Yes,
It's
لكن بما انه في
possible.
بريكاردي ديفيوجن المفروض يكون في رب يعني صح؟
No, not necessary, not necessary. There is a small effusion, it's not necessary. Not all patients have the pericardial rub.
Good.
Yeah.
Okay, thank you, Dr. Abdullah. You can
Thank
read your scenario in the chat box Dr. Aisha sent.
Okay.
Okay, Miss asked to see Mr. Appleby. What's this name? Appleby. 45 years, truck driver, suffered collapse earlier in the day. He's 45 years, lorry driver. Mr. Appleby. Make it easy, Mr. Ali. No need for this name. Okay? 2 minutes, then we'll start. By the way, the doctor asked for PE. In any serious chest condition or something you suspect, you have to put it in the differential. And also you can roll it out by a specific question and put it in the differential at the end. And you can also admit the patient for the serious suspicions.
I'm waiting for your comment, Dr. Bess.
Yeah, yes, you did well, Dr. Aisha. You reached the diagnosis. Sorry, I was busy a little bit. Okay, for
I
your
suspected that.
for
Yeah.
your performance, yeah, you did it great, really. You reached diagnosis, which I didn't reach because I thought it's not pericardial since the examination not going with the pericarditis. But the typical signs in the chest pain going with pericarditis, but I don't know. In the examination, it was like distracting, so I didn't. But you reached the diagnosis. Really great. And the differential also you ask about the PE, but I'm against also to ask about autoimmune. However, the age is not necessary, so it might come also in old age, the autoimmune complication, especially she has the ischemic heart disease earlier. But in general, you rule out the most serious association or complication or causes of chest pain, which is ischemic heart disease, pneumothorax, PE. And here pericarditis related to the surgery. For myself, I put pneumomediastinum, which is also not serious and it's not painful. But the pericarditis is typical chest pain while lying flat and improve with bending forward. So it's from you catch it from the first question. That's why you did the case very comfortably. Well done, Dr. Aisha. And sorry for the
This
late call.
really from Dr.
Yes.
Abdullah. Thank you for him.
Yes. Yeah. Okay, thank you. Let's go to the next scenario. I will adjust the timer. Dr. Abdullah, you ready?
Just give me a minute.
لحد ما يجهز طلع البلسس بارادوكسس حق الكاردياك تمبونات وبريزنت برضه في البريكارديا فيوجن لكن شوية رير والكوزمال ساين رير في الكاردياك تمبونات وبريزنت في البريكارديا فيوجن البريكارديا
Constrictive pericarditis. Yes.
أيوه.
So in each condition present in one disease. The cosmal with the constrictive pericarditis and the pulsus paradoxicus with cardiac tamponade. So you can say this is characteristic for this and that one characteristic for the others. Dr. Hunaida already shared to the chat box. You can see this figure. Pulsus paradoxicus present with cardiac tamponade.
كانت مكتوبة واضحة كده في باست ميديسن.
Yes, this
مكتوبة
is
هنا رير وهنا كومون هنا
exactly. She shared it from BAS test. Sorry, from BAS medicine. I will share it to the group. Thank you again, Dr. Hunaida. I will share it to the WhatsApp group. Actually, she shared it to the WhatsApp group also. I thought it's only here. So it's clear now. I remember also with the asthma or asthma exacerbation or something like that. The increase in the calibration also can cause this pulsus paradoxicus or cosmal sign, one of them. I cannot remember which one, but it's also there. Cosmal sign for constrictive, yes. Good, yes. Good mnemonic. Thank you, Dr. Hunaida.
Yes, I'm ready.
Yes, timer there. You can go.
Okay.
Hello.
Hello.
I am Dr. Al-Malla, one of the medical doctors here. Am I speaking with Mr. Ali? And you are 45 years old.
Yes, I am doctor.
I hope you are comfortable today here. I'm here to take a history from you, examine you, and address all your concerns. I will be writing notes just to help me memorize things. I hope you are not bothered with that. Could you tell me what brought you here?
Well, doctor, I really just began my all conscious now. Just it is very bad like event happened today. It is really unacceptable. First time to me to have this problem. I just suddenly collapsed while shopping. These the people tell me really when I come here, because just the last thing I remember that I am walking in the supermarket and I noticed some smelling strange, and after that really I don't know what. Just I found me myself in the ambulance.
I hope you didn't injure yourself badly.
Yes, doctor. I injured my head.
Where?
I feel
In the hand?
head.
Okay.
My head.
A head, okay.
Yes. Yes, I have
And
some
are
headache
you
right now.
okay? And before you didn't have any headache before? Do you remember anything before this
No, I am
collapse?
really nothing, no anything. I trying to remind me. I am very good at the morning, and I'm going for shopping.
And that day you were not like tired or feeling you didn't eat your meals well.
No, nothing. I think nothing from that.
Okay. And were anybody informed you that measured the sugar in the ambulance, or how was it, the sugar, your blood sugar?
No, doctor. No. I didn't ask. You are the first doctor I speak to him.
Okay. So we'll offer you painkillers at the moment to ease the pain. I will ask you more questions. Do you see any problem in your vision or double vision at the moment, or any blurring in your vision?
No, doctor. Right now I feel better and I can see good, no problem.
Okay. And was there any feeling of chest pain ever before you fell?
No, doctor.
Okay, like ever before even days before you fell?
No, I
Okay.
don't have any chest pain before.
Okay, and any racing or feeling of your heartbeat pounding?
No, doctor.
Okay, and any feeling of dizziness throughout these days?
No.
Especially when you stand up? Okay. And was there any pain in the body anywhere else? In the head or anywhere in the
Before
body?
that,
Okay.
no, I have no any
Yeah.
problem. Yeah.
Okay. This happens with you, right?
Yes,
Ever.
first time.
Okay.
Yes.
Okay. And was there any did you have before? Okay. Did you you said you felt something a weird feeling or weird taste or something like that?
Smell. Yeah, I found those
Smell.
like
Okay.
this is the last thing I remember. That yeah.
Okay. And can you describe me this smell?
It's like smelling something strange, doctor. Just this is just the last thing I remember. After that, I was in an ambulance.
Okay. And do you remember for how long they told you have lost your awareness?
They said
For how
it is. I think it is. I already regained my aware, but I still confused. I can't be communicate with others till I am in ambulance. I don't know exactly, doctor, the time from.
Okay. Was there any shaking in the body?
Yes, you're right. They tell me that I have some shaking for 4 to 5
Shaking in the body.
minutes. Yeah, for
4 to 5 minutes. Okay.
Yes.
Okay. And your eyes were turned white?
I
I
don't
think.
know, doctor. They didn't tell me about that, but they tell me about the shaking. The people around me when I arrive here in hospital, they come. Yeah.
And all the body or only part of the body when
I
this
think
shake
they tell
started?
me all. They tell
All the
me
body.
like shaking of all my body. Yeah.
Okay. And okay, and let me ask you, did you have any like I'm sorry for the question, did you wet yourself? Did you feel yourself wet in the urine?
No, not really.
Okay. Okay. So in the I want to ask you, in the past, do you have any known medical conditions before?
No, doctor, I completely well.
Okay. And do you take any in the family? Do you have any family history of these convulsions or seizures or jerking
No.
episodes like this? Okay.
No.
In the friends or the family? Okay. And I want to ask you, do you take any regular medications?
No, doctor, no any.
And I'm sorry for the question. Do you take any? I'm sorry for the question. Do you take any illicit medications?
No, never, doctor. Never before.
Never. Okay. And do you smoke?
Yes.
Okay. How many cigarettes and for how long?
About
Can say?
10 to 15, doctor, for past 20 years, I think.
Well, smoking is quite dangerous over the overall health, and we will do the best support for you to help you quit smoking. Is that
Okay,
all right?
I'll think, doctor, yes.
Yeah, and do you drink alcohol?
Yes, doctor.
And how many glasses and for how long?
I drink only, doctor, at weekend, Friday and Saturday, like 2 to 3 pints.
Okay. So it is below the, is it below the
Yes,
recommend?
exactly.
Okay, that's all right. And do you feel your eyes are getting yellow, or anybody told you that you are your yellow skin or your yellow eyes?
No,
Okay.
doctor.
And did anybody told you that you are paler than usual?
No.
And did you have any fever or high temperature feeling?
No.
Did you have any feeling of sore neck or stiff neck movement?
No. It's okay. No, it's okay.
Did anybody notice that you are behaving weirdly? I'm sorry for that.
No, doctor, no.
Okay, that's very good. Okay. Do you have any loss of balance?
No.
And do you notice that you are before these days, before this collapse, did you have any problem with expression muscles in your face or any mouth deviation?
No, any, doctor. I didn't.
Any problem in the speech?
No.
And was there any problem in the swallowing?
No, doctor.
Any weakness in the hands or legs?
No.
Or any abnormal, any problem, weird feeling or sensation or numbness in the hands or feet?
No, doctor.
Okay, good. And any loss of control of the urine or the waterwork or the back passage?
No, doctor.
Very good. Okay. What do you do for a living, Mr. Ali?
Yes, doctor, I am a lorry driver.
Okay. Actually, this is quite dangerous for you and for the public. At the moment, you need to stop driving for until further notice. Is that all right?
Oh my God, doctor. I am the one supporting my family. I am self-employed. This is my job.
I'm sorry for that. We may involve the social worker to see how can we manage about that.
For how long, doctor? I will stop this.
I'm not sure about this at the moment. It depends. We may need to control first with medications, but at least to my knowledge, at least you need for like almost months, but I'm not sure exactly.
Well,
I
doctor,
will speak with the people of expertise about that. Is that all right?
yes, yeah,
Okay. May I examine you?
okay, sure.
Okay, I will confirm the same observation chart.
Okay, there is all
Okay.
the vitals stable. Yeah,
Okay, I will ask him to walk. I will see the gait first.
it is normal gait.
Okay, and heel to toe. And then before lying, I will ask him to close the eyes if the Romberg test is positive.
No, negative.
Okay, and then I will check the lymph nodes in the neck.
No,
Okay, I will ask him to show me the eyelids for pallor and
no,
jaundice. And I
no,
will ask to protrude the hands. Can you extend their arms? I will see if there's any tremor. And
no
then
tremor.
I will look in the and then the pronator drift.
No perimeter there.
And then I will check the pulse.
Okay, equal bilateral, no problem.
Regular.
Yes,
And I will check I will ask him to that I will move the hands as if he doesn't have any pain. I will check the tone,
okay,
power,
normal.
and the reflexes
No,
and sensations.
no,
And then this if there's any cerebellar manifestations. So if can move the hands
to
without
nose is
any tension
normal
tremor.
if you need to do.
Yeah.
Okay, no
Yeah,
problem.
finger to nose, yeah, and
Yeah.
okay, sensation. And I will ask that I will auscultate the heart, very importantly.
Normal.
So if there is no murmur and the aortic area, there is no ejection systolic murmur.
No.
And if there is any carotid bruit,
No,
okay, okay, and the nails, is there any periangual fibroma or anything specific or facial any problem like
No.
characteristic faces? Okay.
no characteristic.
May I know, Mr. Ali, what is your concern?
Well, doctor, what happened to me?
Actually, from what you have, from what after I asked you questions to history examine you, it looks like you had an episode of seizure. It's basically jerking movements due to the result of with altered level of consciousness because of increased electrical discharge, electrical firing in the center of the cables of in our body, which we call seizure or
Okay.
so this is based on what you say, looks like a first episode ever with you happens.
It can happen again, doctor?
Yes, quite risk for you, high risk to happen again, but we will involve the nerve doctor consultant and a multiple team approach to help in that regard. We may need to start medication after discussion with a nerve doctor and after doing further scans of for the head. Is that all right?
So you can prevent this from happening again, doctor?
We can prevent, but certain measures also in the lifestyle modification need to be taken, quite importantly.
Okay, doctor, thank you.
Okay. To complete my examination, I need to examine the cranial nerves, lower limbs. Yes.
Okay, time is up.
Okay.
Yes, let's move to the examiner questions. Dr. Aisha, start.
Okay. Well done, Dr. Abdullah. Can you present finding you found from the case, from the history and examination?
Mr. Ali is 45-year-old, presented with the first time episode of seizure that is manifested by loss of consciousness from the witnesses. The collateral history, they have informed that he has lost of consciousness for almost minutes, 4 to 5 minutes, and with altered level of consciousness of drowsiness afterwards, which implies a post-ictal period likely, and there is jerking movement in the body, but there is no good clear history regarding the episode itself, regarding the drooling of saliva or the uprolling of the eye or the sphincter loss control during the event. Tongue biting is important sign here that I should have explored, and also
You didn't explore.
no. So
He has
there is
tongue biting.
a head. Yeah,
Yeah.
I didn't.
Okay.
I didn't. Yeah, and there is
Okay.
a head injury because of that collapse.
Okay. So the
Based on
differential is
that,
firstly, yes, it is seizures. So what is the
yes,
other differential you will put to
other
exclude?
differential. Yes, other differential. If we need to exclude a cardiovascular disease with secondary seizure due to the cardiovascular insufficiency of blood supply.
Any
Third
other?
differential is vasovagal episode with a seizure, which could have been the seizure, but less likely.
Any other?
Any other is hypoglycemia.
Excellent.
Could
Any
be
other?
a differential here. Yes. Could be.
The thing is that you ask about it a lot of questions and you examine about it.
Yes, aortic stenosis.
TIA.
TIA.
TIA,
Oh God.
yes,
TIA.
you ask
Yes.
about.
Oh God.
Okay.
TIA. Yes.
So, okay.
Transient
So,
ischemic attack. Okay.
okay, how will you investigate this patient?
So he will need a baseline. He will need a baseline investigations of routine tests, blood tests, looking for inflammatory markers and blood counts, and then kidney function. Importantly, to help see if there's any associated acute kidney injury with dehydration, or if there is to help as a baseline test whether there's any benefit to start antiepileptic medications. And also liver function tests to see if there's any other reason of this seizure regarding
mention the test. Yeah. Just mention the test.
Liver toxicity. Yes, liver function test. Urine toxicology. Despite that, he said he doesn't take, but we need to test. And also we need to do blood sugar level immediately on the scene of medical assessment and during follow-up. We need to do imaging of CT head with brain to rule out any fracture and hemorrhage, and to see if there is any lesion or mass, to rule out any other pathologies in the brain, and also plus or minus MRI if that is normal.
Anything else?
Later on, EEG studies as outpatient could be done. And
so how will you manage after?
So patient, so non-pharmacological in terms of patient education about the event that happened and the most likely diagnosis and how to avoid the triggers. he will need a discussion with the multidisciplinary team approach, and will involve the neurologist, the medical team, the neurologist, will involve also the specialized nurses and occupational therapy and social worker, because he is driving. And also he may need actually he may need discussion about starting antiepileptic medications given his high risk job, and the risk of recurrence. There is the risk. This is the first seizure, though, so there is a discussion whether to start antiepileptic medication or not in this case.
Okay, according to the course. Okay.
Yeah.
Okay.
Regarding investigations, I have missed that he needs cardiac investigations, ECG, echo, and carotid Doppler. Yeah.
Okay. Thank you, Dr. Abdel. Well done.
Thank you. Thank you, Dr. Aisha.
Okay.
Okay, well done, Dr. Abdullah. Thank you, Dr. Aisha, for the case. You can commit now, Dr. Aisha.
Okay. He will done it. Just you come late with describing the event. Okay. So we will put in mind any collapse. We will see pre-event and event and post-event early in the discussion, so
Yes.
it can help you to go forward toward the problem. So this patient has seizure. So you will focus about the neurology, and you can include some screen for other possible causes. You did well in excluded other causes, like any meningitis, like any TIA, like any hypoglycemia. But just you can focus more with causes of seizures by more questions than the cardiac question, because you, from the history, you elicit, you found that it is not cardiac. Most probably, we will do a lot investigation after that, but it's most probably it is a seizure. No anything in history suggests it is a cardiac, okay?
Yeah.
No any before or after or during something that will you think about cardiac. So just you focus a lot on cardiac and missed something that is important to ask about the seizure. So you ask about dizziness and visual, but you missed the nausea and sudden onset headache before. You ask about the fever and rash, and this is good for meningitis. You ask about the
I
weakness.
asked about headache before, by the way. You said there is not headache before, and
No,
it's only after.
Maybe it is like you will exclude sudden like subarachnoid hemorrhage. So you can just mention you said that you have any headache this week, I think. So I don't
Any headache
remember
before
exactly.
the episode of collapse.
Okay. So the trigger of the collapse, you should ask what you do when this happened, and I'll tell you before asking. You will ask about sleep. Do you have any lack of sleep? You are drinking a lot last night. You have any recent illness? Also, you will ask about the diet and if he is lost a meal or like that. Okay. This is all the history and the confusion after, and there is something called TOD paralysis. It is like transient limb weakness. You can ask by name, there is some weakness after this episode you felt, and he can tell you, yes, I have some weakness, like amnesia. Also he can lose some memories or some short-term memories before the episode. Okay. Also, he bit his tongue, so you can ask about after incontinence. You will ask about the tongue, and in examination you will find him any problem, and you will examine the tongue. Okay.
Yes, yes.
You ask about the medication because there is some medication can cause this problem, and you should ask. You ask us. I think you ask about the weight loss. Any recent weight loss?
No, I didn't.
And the sexual history very important here
Yes.
because you may have mass in the brain. You may have a tumor or may have infection from HIV, or mass from HIV also like lymphoma or something like toxoplasmosis, like that. So this is a 2 point also important here.
Yeah.
Social history, like alcohol, very important here. You ask about drinking, but you should ask what it happened last night. You drink a lot. Do you have? Do you sleep good? Okay, because this is triggers. Okay.
Yes, yes.
For driving, yes, he will stop, but you should inform also. You should inform the DVLA. Because this is important. He should inform because if something happen,
He
will
should
not
inform,
cover
yes.
by insurance. Yes. Okay.
He should inform. I will not inform. He should.
Yes,
He will.
you will tell him, please inform the
Yeah,
DLA.
yeah,
Stop
yeah,
and
yeah.
then please
I should.
inform.
Yeah.
Okay.
Yes,
Yes.
yes.
Okay.
Thank you.
And the
Very important.
first seizure, after the scanning, they will decide. It is generally after the scan. Nothing in the scans, so it's unprovoked. It is 6 months. If it is for type
yes.
1 driving, for type 1 on driving for a simple car, okay? And it is for 1 year. If it is there is
Lorry.
something, no lorry, it is 5 years.
5 years.
5 years
So this man
and
5
10
years,
years,
yeah.
and 10 years if
Done.
it is provoked. It's something
Okay.
happen and
Okay.
he should be free for 10 years. Okay. So it is long period. You ask that you will ask and tell him it is better if you will not remember that from stress of exam. Okay.
Because lorry driver, you brought me. So it's like
it is.
that's true.
I bring it as in the book. Okay. Okay.
Good.
In examination, you did well. That any features because you will search like any neurofibroma, tuberous, sturge paper. This will have seizure with it. The disabilities. For also you will check the pupil. You missed the eye examination. It is important.
Very important.
You will
Oh,
check
God.
the pupil and you will check the field and the eye movement. These three. And you will offer after this fundus, but you will not do. As you said in the last, you will offer the fundus and the warning and the other exam. Okay. But just examine the eye is very important. You can screen for cranial, but no time, but just start by eye and hand. So you can make like rapid screen if you found anything, because maybe this patient have really ischemic attack and it is like complicated by this.
Yes.
For examination, I reflex, as you said, and cerebellar and the gait. Also, the rash, you like observation, you will like make observation for limb, okay? The neck stiffness, very important. You ask about it, but you didn't offer to do.
I should
okay?
offer to do.
You should offer, yeah. The heart examination is good, but you will not, you will listen to the heart.
Offer it.
No time, yes, no time to listen to all and the carotid. So just listen to the heart. If any murmur you notice or no, or any problem you can list. And you will say, I need to do fundoscopy and I need to full neurological and cardiovascular examination for this condition. Okay. For differential, as you said, very good differential for you. It is cardiogenic or hypoglycemic or seizures or transient ischemic attack.
I forgot actually electrolytes. I forgot the electrolytes.
Yes, it is yeah. Electrolyte also, yeah. Okay, so investigation, you taking too time to, and you should start by the most important. If this case come to you and ER, you will take sample for full blood, but just you'll mention this as a point. We will plan basic investigation, and you'll justly after this point I'll do urgent city. It's very important to start it early in discussion because the examiner wanted to hear this word. So don't take more time to say it. Maybe you can say it first, because in real life you can do it first before even blood extraction. Okay, so you will do CT, urgent CT. According to the result of CT, the MRI will be arranged if you suspect anything. Okay, yes, but you should do CT. For exclusion, if he asks specific lesion, any subacute hemorrhage, any trauma from the incident, from the fall down, okay?
Yeah.
Okay. EEG, it come and go early, not like, you will tell EEG because it is true epilepsy. You found that it's true convulsion, okay? So you will offer EEG also in your diagnosis. Electrolyte and the kidney function are important. ECG is important, echo important, but just this come next year. For management of this patient, it is like first fit. So you will offer neurology. You will arrange neurology meeting, and he will, according to the result of investigation, he will his opinion will follow. Before it, like no any anti-epileptic after first, but now it can you can give even after first if there is wishes of patient, if you suspect to happen again, if there is family history, like that. Okay. Other things for driving, they speak a lot about driving in the book. I think this is all. Anyone have any other comment or something I missed? It?
Should be admitted.
The answer. No, not admitted. Just if you found anything. If you not found anything, and he not reseizure again after arrival, okay, no admission. The point is that to answer, you can prevent doctor this from happen again. It according to the cause. If the cause preventable, we can prevent. And the cause unavoidable, even with medication, we can't prevent. So you can just answer diplomatic answer. In some cases, we can prevent, but not in all cases. According to situation, and it is too early to talk about that. Okay.
Yes.
No definite answer. No. Yes, we can prevent. No, we didn't see like that.
Yes.
There is some word you start the meeting by it. I'll take history from you. No, it is not good word from start. You just take, we will discuss with you the health issue, the health condition. I think the word history is not familiar to the patient.
Okay.
Okay. Other than this, you catch the diagnosis and you manage it good. I think the case well done, Dr. Abdul. Thank you.
Thank you, Dr. Aisha. Thank you.
Yeah, thank you, Dr. Aisha. Well done, Dr. Abdullah. I wanted to say only a few comments. For the investigation, yes, we will try to be target in the investigation. Even me, I am just repeating this advice for all of us and including me. Be target in the investigation. Yes, we are saying basic investigation, but no need to mention all of them. Or you can mention what you want to look for. For example, CBC for anemia, infection, leukocytosis. Apart from this, no need to say coagulation and liver function, kidney function. What you are suspecting, mention. You are not suspecting, go or skip to the specific investigation. This is the first advice. Second advice, you are in the long clinical consultation. You said at the end, I offer to do cranial nerve examination. You can do whatever examination you want to do. It's not short. In the short, they will tell you examine the upper limb. So at the end, you can offer. And I do, I offer, I would like to do cranial nerve, lower limb examination. But in the clinical consultation, you are free to do whatever you want with the patient. from head to toe. Examine whatever you want. So at the end, you don't offer it. You can do it. Okay. Apart from this, yes, you did well, but the tongue biting, it's important, and the pupil examination and all reflexes and the gait. It's a case for neurological examination from head to toe. The finger, the hand, you can do tone and power reflex sensation, fine touch, one sensation, and the deep sensation, one examination. Like the vibration or joint. Joint is easier. Joint and fine touch.
cerebellar cranial nerve also, صح؟
Of course, yes, I'm going now, yes, to going up to the head, full neurological examination of the eye, pupils, fundoscopy, because papilla edema also should be screened here, and cranial, the cerebellar, either in the hand, clapping the hand, or pass pointing, nystagmus, its shape. Cerebellar is very important here. However, the cerebellar stroke will not cause a seizure unless it's a major stroke, posterior circulation or something like that.
In exam, it come like space occupying lesion. So any
Yes,
symptoms we can find. So
yes,
just
exactly.
ask from history and try to make according to your time as
Yes,
much as you can. But important to start by cranial and by upper limb and the gait.
yes,
After
exactly.
that, if you have time, complete. If you no time, just you will mention, I would like to examine the heart. I would like to examine the
Yes,
lower limb.
yes. This others other than the you should examine the heart and the chest, and but the main concern in this scenario is neurological examination from head to toe and the gait as well. This is the advice. Also, I put this advice for me before all of you. Thank you, Dr. Abdullah and Dr. Aisha. Any other comment that you can share? Anyone can share?
Dr. Basim, I don't think there is enough time to do all the examination that you're saying.
Not all.
Yes, really, yes.
I said tone and power in the hand
You're
and the
saying
power.
clarinian, upper and lower.
Okay.
The candidates that did this scenario, it is come like they push the patient towards like there is some problem in his sensation like that. So he will like guide you. If no guide like this case, you just, the eye is very important and you can examine the mouth for bite, and by only also you can just check the tongue because you already opened the mouth, okay? Then check the upper limb, the pronator and power and reflexes. If you did this, if you found that 2 minutes remaining, stop and ask the concern and tell the examiner that when he discussing with you, if he ask really from examination I found some it's normal, but also we need to exclude any lower limb problem, any cerebellar signs, any cardiac problem. If you said that and if you did that and the examiner said that, really they know that no time, but they just need from you that to be systematic and target. You will go
Yes.
directly from your suspicions. Yeah.
Exactly. And the history, from the
The
history you
priority
can.
for system involved, صح؟
Yes, neurology,
كمل
of
كمل يا
course.
دكتور.
Yeah, and yes, this is my point. This case is for seizure. So you have to examine the neurology, and it's clear from the start this is seizure, whatever the cause, and it's not primary seizure, of course, or primary epilepsy. It seems to be secondary epilepsy, either space occupying lesion or stroke. So you have to do full neurological examination. I didn't mean all the steps, Dr. Abdullah, like tone, power distal,
No,
and
you will
no,
not
you
do
can
the
do
tone or
one
power,
test. Yes,
just the
yes,
power and the reflexes. Power
yes. One
plus
reflex only is enough. You
pronator,
can
pronator, and
Burinator drift
then
and Hoffman. You
power.
can do also Hoffman
Yeah, if
as
pronator
upper
negative,
motor.
no need for Hoffman. Okay.
Yes, it's the same. Yes, it's the same.
Yeah. Just
And
you can just then the power and then
Mhm.
the reflexes.
One reflex biceps, for example, or brachioradials, not both.
Yes, if the history negative, if he said in the history no
Yes.
any weakness, no any sensation problem, you will not proceed. If there is something in history, focus on.
The idea here is to pick up any lateralization, because if you have lateralization means there is something in the brain, central cause.
Yes.
Lateralization means either weakness, asymmetrical sensation, affection, like stroke patient or even space occupying lesion. He will come with asymmetrical weakness or asymmetrical sensation problem. So this is the idea of your neurological examination, not the power for the checking what the power here distal or proximal. No, to differentiate comparing both sides. Any lateralization, you can do it once, like raise your both hands. He will raise the hands and raise your legs. If he's lying flat in the bed, raise your leg up. From this moment, you can know there is lateralization or no. He can raise one leg more than the other or less than the other, or the arm as well more than the other. So you can know there is lateralization. If there is lateralization, you can proceed for the steps of neurological examination, full steps. But if no, just do one step, one examination for each, like power and the reflex, then the face, and focus on the sensation over the face. Not all examination, because if even you will do, the time will not be enough. The eye examination and offer fundoscopy, of course, and that's it. I think the heart and cardiac and the chest is not important in this page, but you can tell to the examiner at the end, I would like, if I have time, to screen for the heart, carotid. If I suspect aortic stenosis, for example, if suspect carotid stenosis.
Mm.
Yes, this is the point. But you did well, Dr. Abdullah. You did the case well, and you reached to diagnose. Yeah, this is the last case. Okay, I think time is late. Any comment else before ending? Thank you, Dr. Aisha, Dr. Abdullah. Nice cases.
Thank you.
Both
Thank
of
you.
you, nice performance. No question? Yeah, thank you too. Thank you, Dr. Abdullah. I don't know if you are still with us. I think he left. Okay, see you tomorrow, inshallah. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام.